Hello, everyone. I'm Andrew Watkins, and I would like to welcome you all to our podcast for the Nebraska ASAP Antimicrobial Stewardship Summit. Due to the COVID-19 pandemic, we were unable to host the 2020 Nebraska Antimicrobial Stewardship Summit in person. So rather than create another Zoom conference or series of live webinars, we chose to pursue a podcast series format. We will have episodes with experts in the state to discuss antimicrobial stewardship topics relating to both acute and long-term care. CE credit will be available through Creighton University, and more information will be available on the host site regarding claiming credit. I will be moderating this part 2 episode and would like to welcome today's speaker for his second appearance, Dr. Salman Ashraf. Dr. Ashraf serves as the medical director for Nebraska ICAP, as well as the co-medical director for Nebraska ASAP, our state's infection control and antimicrobial stewardship teams. He's also an associate professor in the Division of Infectious Diseases at the University of Nebraska Medical Center, and is board certified in internal medicine, geriatric medicine, and infectious diseases. Welcome back, Dr. Ashraf, and thank you for joining us today.
Thanks, Andrew. It is great to be back.
And so today we're going to be dissecting the UTI guidance for post-acute and long-term care settings that was published by the American Medical Directors Association, or AMDA. In part 1, we focused on more background information and diagnosis of UTI, while this part 2 episode is going to focus more on treatment, prevention, and antimicrobial stewardship strategies. And so, Dr. Ashraf, in part 1, we briefly mentioned the clinical criteria used to diagnose urinary tract infections. And I know you wanted to recap what some of these clinical criteria actually were. Would you mind letting the listeners know what these criteria and symptoms contain and include?
Yeah, so the criteria I mentioned last time were the Loeb's minimum criteria, the AHRQ communication decision 8 tool, the IOU consensus criteria, and then the international Delphi criteria. All of these criteria have some minor differences, and they use various combination of signs and symptoms to decide when to pursue the diagnosis of UTI and when to start the antibiotic and when not to. So whichever criteria a particular post-acute and long-term care setting adopt, they can follow that criteria every time when assessing their resident for suspected UTI. We didn't prefer one over the other in the guidance when we were recommending, because there are no head-to-head trial kind of comparing those criteria. The basic concept we need to know at all times are that what are the localizing signs and symptoms for UTI? And those are usually dysuria, new or worsening frequency, gross hematuria, suprapubic tenderness, and new or worsening urinary incontinence or urgency, which can all be present in cystitis. Now, if somebody has costovertebral angle tenderness, that might indicate symptoms maybe localizing to the kidneys. The other things that we need to know in addition to the localizing signs and symptoms is the warning signs, or in other words, signs that indicate systemic infection, which sometimes can accompany UTI, but can also sometimes accompany other infections too. So examples of those warning signs are fever, rigors, chills, clear-cut delirium, as we discussed earlier, and unstable vital signs. Not just a behavioral change, but a clear-cut delirium, and then unstable vital signs can also be part of the warning signs that we have to look for, which, if present, may mean that if we are suspecting UTI, is it being now have systemic involvement, which will be managed a little different than an uncomplicated cystitis or acute simple cystitis will be. So I wanted to kind of have it out there before we start talking about the treatment and all those.
Perfect. And thank you for recapping that. I know that's really helpful to have in mind, especially as we pivot now more towards management. And so say you've gone through the proper diagnostic procedures. Now you have a patient who you think has a UTI. How should these patients be managed empirically? I'd love to hear your thoughts on supportive care measures, as well as what empiric antibiotics you would typically want to start.
Yeah, so let's go step by step here. First, talk about those residents who are meeting the clinical criteria for UTI based on whatever the criteria you are using, whatever the standard criteria you are using, and have severe signs or severe symptoms with evidence of systemic infection, or warning signs that we talked about. So somebody who is meeting the clinical criteria for UTI and also having signs, symptoms, or warning signs. What are we going to do in that setting? So in that scenario, it is recommended that clinicians should consider empiric treatment with broad spectrum antibiotic agents, and then de-escalate the antibiotic based on the results of the urine studies and the clinical course. So they have sent that before they're starting the antibiotic, and now they started so you did the urine testing, you sent it out, you started the patient on empiric broad spectrum antibiotic, and then once the culture results are back, we'll hopefully be able to tailor the antibiotic treatment accordingly, and will no longer need to continue the broad spectrum agent any further. So for a short period of time, it will make sense because the patient is really sick, and you will have to start that broad spectrum agent, but then de-escalate once your culture results are back, and you may have a sensitivity results on those cultures that you may be able to follow and target. Now, for those residents, let's talk for a different resident population. For those residents who are meeting the clinical criteria for UTI and has mild symptoms, okay, then these are the residents who do not have any warning signs. Then we can start on treatment. These residents, we can start on treatment after sending the UA and urine culture. Now, we don't need broad spectrum antibiotics all the time in these patient population. The antibiotic we choose here should depend on the couple of factors. If there are previous culture results available from the past 6 months to 2 years for the resident, that can give us an idea of what antibiotic we can use. We can review those urine cultures and can decide on antibiotic that way. If that is not available, then look at the local resistance pattern, like an local antibiogram, and choose options based on the antibiogram. What appears to be more sensitive in your area, which antibiotic appears to be more sensitive to the common pathogens in your area. So in general, the first line agent for treatment of uncomplicated cystitis or acute simple cystitis is either nitrofurantoin or trimethoprim sulfamethoxazole, which is also known as Bactrim. So those are usually the first line agent when we are thinking uncomplicated cystitis or acute simple cystitis. Now, fosfomycin is also another first line option, but usually is reserved for situation when we are suspecting multi-drug resistant pathogen. That is when we use the fosfomycin. Now, ciprofloxacin or levofloxacin, they are not considered first line anymore due to the high resistance with the use of these antibiotic, and also a lot of side effects and black box warning associated with their use. Another options people use are like oral beta-lactam antibiotics like amoxicillin, clavulanate, or cephalexin, etc. And those are also considered second line agents. And then one other point that I'll mention is that if we are suspecting infection spreading beyond the bladder, because all I just talked about the first line option, second line option, I was thinking more in terms of uncomplicated cystitis or acute simple cystitis, which is basically the same thing, which is infection limited to the bladder. Now, if we are thinking that the infection is extending beyond the bladder, so somebody who has fever along with dysuria, it may mean that it's not just involving the bladder. It is actually probably going beyond the bladder and maybe having systemic involvement. That person, we shouldn't be using the fosfomycin or nitrofurantoin in that situation, because they will not be able to have impact on pyelonephritis, because they're concentrated mostly in the urine in the bladder. So that's an important thing to consider. Let me summarize. I think in terms of in terms of how we are deciding to use the antibiotic, number one thing is we should know the patient history. We should know if they have previous culture results, what have they grown in the past in those culture results, and if they do not have a previous culture result, then we have to look at our local antibiograms and then decide based on that which antibiotic is going to be the best for a patient to use. I hope that answered the question here.
No, it did. And I especially appreciated the points on nitrofurantoin and phosphomycin being used specifically for acute uncomplicated cystitis, because that's a really common pitfall and a common kind of teaching point and counseling point we run into a lot of times. So once these empiric therapies are started, are there any time points when clinicians can reassess their antibiotic selection, or if antibiotics are needed, and consider either switching agents or de-escalating therapy?
Yeah, I think what you're referring to, Andrew, is a concept that we call the antibiotic timeout. In general, 48 hours may be a good point to do an antibiotic timeout, as by this time we will most likely have the urine culture results back. And we can then make sure that the organism identified on the culture is sensitive to antibiotic that we started. Or maybe if we started broad spectrum antibiotic, we can now go back and use more targeted narrow spectrum antibiotic based on those culture results that are back. Sometimes, I've started the patient on antibiotic and 2 days later, the patient is doing great. And the organism that is growing is resistance to the antibiotic that I have started. Well, that tells me there that maybe the patient was not having UTI related symptoms, otherwise probably would not have improved. And, and at sometimes, I take that opportunity, or probably most of the time, I take that opportunity and stop the antibiotics at 48 hours in those type of situations, because if the patient was getting better, the symptoms were getting better without getting an antibiotic that was that would have worked in the organ to the organ that would have worked against the organism that was growing, it probably mean that that it was not a UTI in the first place. It probably was asymptomatic bacteriuria. So that's something to kind of keep in mind. An antibiotic timeout process helps us make those kind of decisions. The other question, I think, is how long the antibiotic needs to be continued. And usually for uncomplicated cystitis, the duration is usually less than 7 days. If we are using Bactrim in women or trimethoprim sulfametazole in women, let me rephrase. If we are using Bactrim or trimethoprim sulfametazole in women for the 3 days time frame is usually good enough with that. 5 days is good enough if we are using nitrofurantoin. 3 to 7 days are recommended for beta-lactam agents. Phosphomycin is usually a single dose, and fluoroquinolone is also usually used for 3 days when it is used. So again, antibiotic timeout also helps us to make sure that the antibiotic duration is correct and still, it is still okay to continue with that dose, with that duration. If there are male patients or women with uncomplicated cystitis who may be at higher risk of recurrence or complicated infections, such as those with obstruction, instrumentation, impaired voiding, metabolic abnormalities, or immunocompromised status, even then 7 days duration might be enough for most of them if they have a prompt response to the treatment, meaning they improve within 72 hours. Now, longer duration of 10 to 14 days may only be needed for those who had a delayed response to treatment. Again, if we are reevaluating the patient at around 48 hours or so, we can make those decisions. But if we would not have evaluated the patient at that point, then those decisions would have been difficult to be made. So that's why I think it's important to reassess in about 48 hours or so. What else I wanted to say? I think one other thing that I want to add is that for for those infections that are extending beyond the bladder, like pyelonephritis, 7 to 14 days durations are usually recommended, depending on which antibiotic is being used. Fluoroquinolones can be effective when we give it for just 7 days. Trimethoprim sulfamethoxazole or Bactrim, it might be needed to be given for 10 to 14 days, although sometimes 7 days, 7 to 10 days have also been shown to be effective for trimethoprim sulfamethoxazole. And for beta-lactams, in cases of pyelonephritis, 10 to 14 days might be needed when treating pyelonephritis. And again, we have to understand that if we are using the beta-lactam agents, especially the oral beta-lactam agents, as treatment for pyelonephritis, it probably has to be started with an IV antibiotic first, intravenous antibiotic first, and then once the patient starts to improve, then at that point of time, you have the sensitivity back, then you can probably use it. It's never a first-line choice.
Perfect. I appreciate you talking about the timeouts, but especially those durations. I know it's a topic that has a lot of nuance, and there's a lot of different classifications and different agents. And I thought you did a really good job of summarizing kind of what our recommended durations are based on the evidence that we have available. I want to pivot a little bit now from treatment into prevention. And so, what are some UTI prevention strategies that are commonly seen or discussed? And is there any evidence to support these strategies for prevention?
Well, we're talking about prevention. The intervention which appears to be the most effective intervention is use of vaginal estrogen application in post-menopausal women. In addition, I will say that it should definitely be considered to treat atrophic vaginitis, as atrophic vaginitis symptoms often mimic UTI. We know that lack of estrogen and loss of lactobacilli in the vaginal flora and increased periurethral colonization by E. coli may contribute to increased risk of UTI in older women. So postmenopausal state is also associated with vaginal atrophy. Therefore, using topical estrogen makes sense theoretically, and studies have shown that benefit those patients who have vaginal atrophy, but also helpful in preventing UTI. So in short, basically what I'm saying is that the topical estrogen application is the intervention that not only theoretically makes sense, but also has been shown in the studies to be effective in preventing urinary tract infection, and definitely also helpful in treating atrophic vaginitis. Beside the topical estrogen use, none of the other agents we looked at were very convincing for the use of preventing UTIs. The cranberry studies has mixed results. Some studies shows benefit, others didn't. So there cannot be any conclusive statements made towards the use of cranberry as prevention of UTI. And similarly, long-term use of methenamine salts were also not beneficial in preventing UTI in the studies that we were looking at. Now, antibiotics, they may reduce the risk of recurrent uncomplicated UTIs. They may, but the potential harms associated with their long use, coupled with the fact that the prevalence of multi-drug resistance organism that we see among post-acute and long-term care residents, it basically argues against long-term antibiotic prophylaxis. If someone is having recurrent infection and there is an underlying reason for that, and they are about to have an intervention in the next couple of months to get that fixed, maybe for that short period of time, it may be reasonable to use antibiotic prophylaxis. But for more routine long-term use, it's usually not going to be that helpful and even safe in the long run. So, in short, I think the only real proven kind of efficacy is from the vaginal estrogen in postmenopausal women.
Yeah, the prevention aspect was something I'd not been as familiar with and have not looked into as much. So I found that section of the AMDA guidance particularly helpful to kind of get an idea of what we could do there. For the last couple questions, I want to shift and talk about one of my biggest areas of interest, which is antimicrobial stewardship. And really, UTIs provide great opportunities for stewardship, especially in these long-term care and post-acute care patient populations. And so, could you discuss the role of antimicrobial stewardship, specifically with UTIs, and how stewardship principles could help be used in these facilities?
Yeah, antibiotic stewardship, it can be very helpful in making sure that UTI are being diagnosed and managed appropriately in the post-acute and long-term care setting. It makes us think and intervene in a systemic fashion. You know that the CMS now requires nursing homes to incorporate antibiotic stewardship in their infection prevention and control programs. And if a nursing home is noticing that most inappropriate prescribing in their facility is associated with the diagnosis with UTI, then it will make complete sense to focus the antibiotic stewardship program efforts on the UTI. The CDC has described 7 core elements for antibiotic stewardship, which include the leadership commitment, accountability of the team members, having drug expertise on board in the program, which can be their consultant pharmacists or medical directors who have been trained in antibiotic stewardship, or can be other local infectious diseases experts, or in Nebraska, the facilities can even work with Nebraska ASAP to meet the drug expertise component of the antibiotic stewardship program. So, you know, going back, what are 7 core elements? A leadership commitment, accountability, drug expertise, and then after that, action, tracking, reporting, and education. So these are different things we have to do to meet all the elements of antibiotic stewardship that CDC described. All of these components can be established around UTI management if it is the main driver of inappropriate antibiotic use. And the AMDA guidance definitely document and highlights what steps can be taken to build an antibiotic stewardship program focused on improving UTI management in facilities. If what specific action you will need to take will depend on the cause of inappropriate antibiotic prescribing in your facility. So for example, if you're noticing that most antibiotic prescriptions that are inappropriate are due to the fact that they should not have been started as resident never met the criteria for UTI, if that is the reasons for inappropriateness, in this situation, the best intervention will be to introduce an assessment and communication form like the AHRQ tool, which allows nursing home staff to assess for UTI specific symptoms and then provide them guidance on whether the resident is meeting UTI criteria based on their assessments or not, which they can convey then to the prescribing provider. So as long as nursing home staff has all the tools to assess properly and know whether the person is meeting the criteria or not, they can now communicate directly with the prescriber whether these are the signs and symptoms and whether they are meeting the criteria or not meeting the criteria. That will help stop inappropriate prescribing because because the nursing home staff can now offer in those people who are not meeting the criteria that maybe we can start active monitoring and prescribing provider may agree then once they have given that information. So that's one intervention that people can use when the issue is that inappropriateness is driven by starting antibiotic but not necessary. Now, if the inappropriateness is due to the fact that prescribing providers are writing antibiotics for longer than recommended duration, then in that case, the best intervention might be to introduce a facility-specific guidance document that directs everyone about the recommended duration for UTI And the nurses should be able to communicate with prescribing provider about the facility specific recommendation on duration, and let them know that this is what our facility recommendations say for this diagnosis. And it will still be up to the physician to give the final recommendation, but just by letting them know what your facility specific guidance is, can give them an idea that or may help them reconsider if they were thinking a longer duration. And if the issue is that most inappropriate prescribing is coming from the orders that were written in the emergency department or hospitals, instead of being started in the nursing home, then maybe the best intervention will be to ask the medical directors to independently review the situation after resident returns to make sure that they really need to continue the antibiotics or not. Kind of what the concept behind antibiotic timeout is to kind of have a reassessment and see whether this antibiotic was really needed once they have come back to the building. And they have the authority usually to discontinue the order if they find out that the UTI criteria were not met when the antibiotic was started. They can always check back with the prescribing provider at the hospital also if they need to clarify something. So that can be another intervention that can be placed. However, the post-acute long-term care setting try to set this process up, it is going to be based on the data that they have in front of them. You need to know what is the underlying cause of inappropriate prescribing for you to kind of put forward a plan, an action to kind of improve on that prescribing pattern. So one other thing that I was thinking is that how would the facilities go about gathering that data that is necessary? And there are tools to gather the necessary information that will help you make those decisions. And Nebraska ASAP team has on their website a document, an Excel document that is a tracking sheet for infections for the nursing home. And if you kind of use that tracking sheet, it is programmed in a way, pre-programmed in a way that it will give you some of these reports automatically. Again, that is available on the website if you want to take a look at it.
I really like the explanation and the point of needing your own facility specific data. Not every situation is the same, and not every solution is one size fits all. So I think it's really important and really a key point that to have your stewardship committee track some of these reasons, and not just make an intervention, but one based off of data so it has the highest chance of success. So I really appreciate that detailed answer. I have one last question for you, and it kind of piggybacks off of the last question, and that's just where can people find helpful resources for managing UTIs and using antimicrobial stewardship strategies? And do you have any plugs for good resources or any other sources of information where some of our listeners could go and actually see some of this information in a written form?
So Andrew, I think as I mentioned earlier, the best option for the facilities is to go to our website, asap.nebraskamed.com. That is Nebraska ASAP website. And they can find not only all the resources that we have developed, but they can also find additional links to other websites that may have additional information that they can find useful. We have been working, as you know, for the last close to 5 years now, by kind of developing these resources and connecting people to nationally available resources. I think for our facilities, that will be the very, very good start. Another place where I think there is the facilities can use for education is the CDC also has an antibiotic stewardship training series, and it also has a specific module on the nursing home antibiotic stewardship. And I will recommend everyone to take that free course also. So, those are the couple of places I would say that people should look into to find the resources.
Perfect. Thank you. And thank you again for, joining and talking with us today. It's always great talking to you and learning from your vast wisdom and experience in this area. And so we are always appreciative for you to stop by. And
Thank
so
you.
that's going to wrap up our discussion of the AMDA UTI guidance for post-acute and long-term care settings. Once again, I want to thank Dr. Ashraf for taking the time to discuss this topic and give some of his valuable perspective on both optimal management as well as stewardship strategies. I'd also like to thank everybody who's listening into this podcast, and we really hope that it was informative and it was a valuable experience and good use of your time. We look forward to discussing even more stewardship topics in our future episodes of this podcast. And with that, I'm now going to sign off and wish everyone good health and safety as we continue to navigate this pandemic together. Thank you.